Leading a rapid cycle improvement project was certainly a new experience for me, and a challenging experience at that. I learned so much about myself, about improvement projects, about engaging a team and clients, and about the idiosyncrasies of my clinical project site and my team. I have come to trust the process of improvement as laid out by the faculty and the Institute of Healthcare Improvement. The rapid cycle improvement project worked well at my site, and it was fairly well received by the team. Without the guidance of the faculty and the IHI, our team, however, would not have been able to attain and sustain the improvements we accomplished during the project. I had no understanding of the process of rapid cycle improvement when I first started working on the quality improvement project. Not only did I have to learn a whole new process, but I had to learn an entirely new language. I was admittedly lost, frustrated, discouraged, and about ready to quit in the planning stage. A timely word of encouragement from Dr. Butler, my faculty advisor, kept me from dropping out. I'm so thankful that I did not allow fear and despair to triumph. The aha moments came in the dissemination course. I could stand back and evaluate the quality improvement project from above. Through the oral and written assignments, I saw aspects of the project I had missed before. I saw the forest and not just the individual trees. Through the dissemination coursework, I came to an understanding of the implications, the processes, and the accomplishments, as well as the team dynamics. I began to understand the why and not just the what. I also saw myself, maybe for the first time, as a nursing leader. This part of my identity had not dawned on me prior to the final DNP project. I can make a difference. I can lead change. Our team consisted of a registered nurse and 3 certified nurse midwives, including myself. This hardly constituted an interdisciplinary team, so I feel I missed out on some potential learning in this area. But I learned other lessons related to this dynamic. I learned that no matter how small the setting or how small the team, leading change is complex and demanding, requiring management of uncertainty, cultivation of cultural and behavioral changes in the team, and supervision of implementation without taking over or micromanaging. One of the most valuable takeaways from this project, teams identify symptoms of perinatal depression and in treating those symptoms effectively. Prior to this project, I knew very little about perinatal depression. I was a new midwife with no tools or experts to help direct my care of clients with symptoms of perinatal depression. I remember well my first client with significant symptoms of depression. I'd done the screening, but I had no algorithm to use and no treatment plan in place and no method of follow-up. I knew I could offer counseling and SSRIs, but beyond that, I knew nothing. I did not know what mental health resources were in my community. I did not know which SSRIs were safe in pregnancy and or lactation, never mind what dosages of SSRIs to prescribe. I did not have a list of evidence-based complementary or alternative therapies or self-care strategies to offer. I was not prepared for a shared decision-making conversation. Now, I'm dubbed the resident expert in mental health. I'm excited because we just hired a psychiatric nurse practitioner to help with births. I hope to glean even more skills from this new colleague. All this learning was accompanied by messy and humbling moments. I felt totally inadequate to lead a team of midwives with much more clinical experience than I had. These midwives already had systems in place for managing perinatal depression, which worked well. Yet they invited me to tackle improving their processes with the goal of improving their outcomes. I had a lot of catch up to do just to learn about perinatal depression. It was admittedly messy leading a team who knew more than I did. Humbling also came in the form of feedback from Dr. Butler. I would turn in an assignment expecting glowing, positive comments. I had invested my heart and soul into the assignment, only to get less than a perfect grade. There were a few positive comments and then lots of opportunities for growth. I was dumbfounded and humbled by my inability to get it right. I chose to follow Dr. Butler's wise counsel most of the time, although sometimes I would make the correction only after experiencing the negative consequences of not doing so earlier. The worst and best part of the entire DNP clinical process was the final presentation. I was so nervous. I was as prepared as I could possibly be. I finally understood my project and had found a way to share my accomplishments with the world. As I started, I was a bit jittery, but as I continued the presentation, I gained momentum and confidence. It was over, and the relief was incredible. The sense of accomplishment rose up within me. I'd conquered the giant of fear of public speaking. The best was yet to come. The project was graded. I opened Canvas with great trepidation. Then I saw it, 100%. But there was more. I read Dr. Butler's glowing comments on the presentation and on my tenacity in advocating for client choice in a professional manner. I was elated. No comment could have meant more. As a labor and delivery nurse, I nearly lost my job by advocating for client choice. The experience had driven me to midwifery, a profession in which I hoped to be able to offer client choice without fear of losing my source of livelihood. Dr. Butler's comments were much more meaningful than she could have ever even imagined. I had not only become a midwife, but I had become one who could professionally advocate for client choice. I'm so thankful for Dr. Butler in this project. I'm thankful to have been one of her babies. She provided me with tough love, which allowed me to grow into my role as a change agent, a resident specialist in perinatal depression, and a client choice advocate. The best is yet to come.